Okay. Right, so hello there. We're joined today by Joyti Saksena. Joyti, you're a hip and knee surgeon. Just want to give the viewers of this video a quick intro to who you are, what you do, where you work.
Yeah, so thank you, Rob, for having me on this channel. I'm Joyti Saksena. I'm a hip, knee and sports specialist. My NHS practice is the Royal Free Foundation Trust, and I also head up a group called Total Orthopedics, which is a specialized group of orthopedic surgeons dedicated to their specific fields within orthopedics. And really the approach is to try to bring that multidisciplinary treatment that we do so well in the NHS into the private sector, and that's our kind of unique selling point.
Fantastic, great stuff. So we're going to talk today, Joyti, or we're going to home in really on cartilage lesions. And by cartilage, we're talking about what's called the articular cartilage or the chondral cartilage. So for anybody who's not quite sure what we mean, this is the sort of the white, shiny stuff that you get overlying the bones on the end of the joint. So we're not today talking homing into the meniscal cartilage of the knee, which is something slightly separate. We're talking about this chondral cartilage, the stuff that, generally speaking, when it wears out, that's the thing that leads to, arthritic changes, if we could say, at the end stages. So to kick us off then, Joyce, so what's your experience with what we want to call biologics? So by biologics, we're talking about things that are relatively sort of new on the scene, things like stem cell injections, PRP injections, other things, maybe things like hyaluronic acid, which is like a synthetic joint fluid. What's your personal experience? Have you seen many positive outcomes from those? And again, maybe tell us a bit about the evidence base for those modalities as well.
Sure. I mean, so the first thing really to understand, where do we get the use? Why is biologics used? And I think this is all down to what is happening in arthritis, osteoarthritis. People used to actually say this is a disease of the cartilage, but it affects all aspects of the knee joint, from the synovium to the surface cartilage to the actual underlying bone. And one of the aspects is the actual articular cartilage. This is the thing that's obviously wearing away with orthopedics, whether it's age-related or whether it's just general degeneration or whether it's post-traumatic arthritis. And the whole process is in orthopedics is that either you deal with the problem or you deal with the symptoms. And when you're dealing with the problem, you end up having really one option, which is to replace the knee. And we're trying to target those patients where they've got problems with their cartilage. It's certainly not bad enough to, replace. And we want to try and, first of all, control their pain better. And secondly, add some kind of positive kind of homeostasis within the knee. I sort of fall shy of using the term regenerative treatment, and the reason is because the science behind this is still relatively unclear. There is evidence of cartilage regeneration in certain studies and that sort of thing, but really it's not designed to promote regeneration. It's trying to aid the natural homeostasis. In other words, what's happening in arthritis, you get a number of inflammatory mediators, cytokines, what we call bad proteins. And what we're trying to do is replace them, with good proteins, with anti-inflammatory mediators, chemicals, to try and reduce that inflammation, which is predominantly the source of pain. Right. And then try and combine that with all the other aspects of lifestyle medicine, rehabilitation, to really get good healing of their joint. And so in terms of, sorry, no.
I was just saying, how would those injections then, from what you described, and the anti-inflammatory and kind of, not necessarily regenerating things, but maybe trying to aim towards reducing the rate of degeneration. How does that differ, though, from the standard things that people might be offered in terms of things like cortisone and steroid injections?
Yeah, so the two common injections that people do, and even currently do, and even I would do in my practice in certain situations, as you say, it's a steroid injection, hydrocortisone or depomedrone, or a hyaluronic acid injection. The steroid is purely working as a pain relieving injection. It's essentially reducing the level of inflammation, but it's not adding any sort of growth factors, any proteins, any anti-inflammatory cytokines. It's just reducing inflammation. And it can be quite good as a pain relieving injection, quite good for diagnostic purposes, quite good to get on acute flare-ups, synovitis, this sort of thing. But it doesn't have a prolonged effect. And also there is potential negative effects with it, where it can cause issues, particularly, preceding joint replacement, lower the threshold of the immune system, infection, this kind of thing. Hyaluronic acid works obviously slightly differently. These are the building blocks of cartilage, the proteoglycans. But again, the evidence that's borne out, and this is over a good 10 to 15 years now, hasn't really shown much in the way of improvement. There are certain, products out there that have shown, reasonable data. And again, they're things that we use, but the effects generally are thought to last, no longer than really 6 months, if at all. So we tend to move away from those things, although they both, have their use in certain situations. The biologic agents work by effectively taking the body's own blood, spinning this down, releasing, or separating the platelets, which are considered the catalyst type cells, and then concentrating those cells and either injecting those back into the knee, or sometimes we do a technique where we double spin them, we break down those platelets to release the growth factors. And that's then injected back into the knee, really to act as an anti-inflammatory kind of medium, but also improve the actual proteoglycan, the matrix, the homeostasis of the knee. And in terms of, that would be the sort of first line, therapy for that sort of mild
PRP you're talking about first, yeah.
Yeah, PRP or platelet derived growth factor, those are the two kind of, when you double spin it, you're actually breaking the platelets down to release the growth factors, or the autologous protein solution. That's another name that people use. But yeah, essentially, PRP, platelet rich plasma, is the term we use. And that will be generally my sort of first line of treatment for patients with, mild, moderate arthritis. People do use it even in grade 3, grade 4 arthritis. But I think, it's one of those things where the earlier you recognize the problem, the better the outcomes are in terms of, when the symptoms first come on. When you've got grade 4 arthritis, there's other processes going on. So it's not surprising that the results aren't as good. And this is where the data is very skewed. When you interpret medical data, you're looking at a very mixed bag of picture. People are using it in all kind of cases and not stratifying it. And that's why you sometimes get this sort of negative, studies showing that, it has no effect, because possibly, their inclusion exclusion criteria haven't been robust enough.
Yeah, sure. And from the patients that you treated personally, what's been your experience in terms of when you get it, get it in the right time, at the right person, for the right person at the right time? Have you personally?
Yeah. So at Total Orthopedics, we very much metric every patient. We would put through an app-based scoring system called My Recovery. We collect that data and we look at it. And so far from around 200 odd patients we're seeing around about 60 to 70% improvement in symptoms, and those symptoms lasting really up to about 2 years. So really quite encouraging, and we're very upfront about telling people, what one would expect. So, not doesn't necessarily work for everyone, doesn't necessarily it's going to improve everyone, but it's certainly a very minimalist thing. You're using your own, blood, it's autologous blood. It's no more than, a blood test, taking the blood off and injecting it into the knee. And therefore very, little side effects, little to really go wrong. And you're not sort of tainting the knee as you could possibly with, say, for a steroid injection, if you're going on to having to replace the knee or something like that in the future.
So you mentioned that was your first line. Where would you go maybe after that?
Yeah, so if we think of the knee as, the knee itself is effectively like an incubator, and the PRP, or the platelet derived growth factor, is really stimulating your own natural cells. It's working on the the natural cartilage cells. But where patients have less cartilage, where their degree of arthritis is more, you really need more cells for that to work on. And that's where the stem cells, or again, that word is sort of bantered around a lot, and generally what we call them is messenger signaling cells is the actual correct term. But for general public, we stem cells is what's known out there. But effectively, you want to you're looking not only to add the catalyst, but you're actually looking to add cells to the equation within the homeostasis of the knee. That's where techniques, such as, bone marrow aspirate, where you're harvesting stem cells from the actual bone marrow, usually from the iliac crest, or from body fat, which is typically the case with techniques such as lipogem, or stem cells, which pure stem cells, where we obtain their allogeneic stem cells, effectively from umbilical cord.
And again, this would be an injection, would it be?
That's correct. Yeah. So again, it's very straightforward. In terms of depending on where you're harnessing cells, if you're using allogeneic, then you would effectively order it, and then you would be processing it, injecting it back in the knee. If you're harvesting it from body fat or bone marrow, then obviously that's a day case.
Yeah. Okay. You want?
Yeah. So if you're harvesting it from bone marrow or from body fat, that would obviously be a day case procedure. The body fat we do in combination with a plastic surgeon, where we're harvesting around 50, 60 cc's of body fat from the abdomen or from the upper thigh. Bone marrow be an aspirate from the iliac crest. And again, both are relatively well tolerated. We've done them even under just local anesthetic, and then processed and put back into the knee.
Alan, given the choice, again, what's your thoughts in terms of given the choice between body fat harvesting and bone marrow harvesting? Do you have a preference? What do you think is most?
It's a good question. I mean, it's not that I have a preference. Often patients will come asking for certain things. I think certainly body fat is thought to have the higher stem cell count. Than bone marrow. It's less traumatic to the patient, less painful in terms of as a procedure, and it's people generally have a degree of fat which they can spare easily. You can argue, pure stem cells, which are the allogeneic, you have even a higher concentration, because you're effectively multiplying, those cells are being taken and then being multiplied in vitro, and that probably give you the highest concentration, and it's considered pure stem cells. But I think the data or the jury's still out in terms of necessarily what provides the the best sort of results, and I still see this as generally more experimental than saying to the patient, well, look, this is definitely going to work. I think there's definitely a role for it. I think the data still needs to be collected, and again, the issue again is this mixed bag of patients that we treat. How you stratify it to actually get meaningful data out of it.
And just to touch on, so what was that you said? Allogeneic. How do we spell that?
Genic. So as opposed to autogeneic from from the body, from yourself, allogeneic, you're getting it from someone else. So it's generally placental. This is the actual we've got a partner called LifeCell, which effectively supply this, and they're MHRA approved, which is a really key factor. The whole stem cell world can be it's generally thought of as quite murky in terms of orthopedic circles, but this is actually MHRA Medical Health and Regulations Authority approved.
That sounds like it would probably be the more expensive of the few versions.
It probably is. I mean, it's in terms of cost, you're probably looking 3,000 to 4,000 for bone marrow aspirate, probably 5,000 to 6,000, 7,000 with lipogems, body fat. Allogeneic is probably in the order of 12 to 15,000, that sort of time. But it's the number of stem cells you get with one injection which is where their real, I guess, marketing benefit is.
Got it. Okay, and then let's suppose now we move it on again. Let's say you talk about somebody who's perhaps they've maybe tried this, or they're even beyond, you deem them to be beyond the scope of those kind of biologics injections, and they've got to the point where they probably are having to contemplate some sort of prosthesis, by which we mean a knee replacement. And that a knee replacement, I'm right in thinking, can come in several formats. We can have a total knee replacement where we're replacing both sides of the knee as plus or minus the kneecap, or there can be a unicarb pump pencil where they're just doing the disease side if the arthritis is all confined to just the inside half or the outside half. in terms of, let's say, somebody who's just got pain or disease on one half of the knee, would you say that it's always best to start with a, unicompartmental knee?
I think, it goes back to you're absolutely right. So that there's I guess a lot of variety, and we're blessed with that. I think the key is, at the end of the day, the patient history and examination, more than anything. So if the symptoms are, predominantly on one side of the knee, if their examination suggests, let's say, let's take medial compartment OA. If the patient, comes in, if you ask him, put your finger, where your pain is, and generally for me, it's a crude test, but if they point all over the knee, then it's telling you that their symptoms are coming from all over the knee. If they point just to the medial aspects of the knee, and their examination is such that they're in, a varus alignment, which is, correctable, largely correctable, and their investigations, their weight-bearing X-rays, which is probably all you need. We often will have an MRI scan as well, and it shows isolated medial compartment OA. And when we say isolated, you still would accept some lateral changes, some patellofemoral changes in terms of radiographs or MRI changes, but the symptoms need to be predominantly, medial side. Then, yeah, absolutely, I think that patient, should be offered a unicompartmental knee. But you need to go again through the consent process. What are the benefits? Well, the real benefit from a partial knee, as you rightly point out, you're just replacing the diseased aspect of the knee. You're keeping the key drivers in the knee, the ACL ligament in the knee, which, is the, considered the driver knee, that's being preserved. So kinematically, the knee functions more normally. It feels more normal. One of the big criticisms, this kind of figure, which is bantered around, 20% of patients having total knees are dissatisfied. One of the reasons is that, okay, well, their pain is improved, but the knee just doesn't feel quite normal, doesn't feel their own. Whereas partials, you can get very close to getting what they call a forgotten knee. We very much achieve it with the hip joint and hip replacements, but with the knee, it's less, the outcome scores are less good. The SF-36 and quality of life indices are less good. So what we're seeing with partial knees is actually it feels much more like a normal knee. The flip side is that the data, and we have very good data, as you know, we collect all of this on the National Joint Registry, which is all in the public kind of domain, which tells us that partial knee replacements are generally, revised around 8 years, whereas total knee replacements, you look at the data and, by and large, most knee replacements, good quality knee replacements are above that 90%, centile over 10 years. So again, when I'm consenting, you typically say to a total knee replacement, 10 to 15 years of use, even longer. Partial, you say it's less than that. But, the trade-off is that, you can do much more activity with it without, much more sports, younger patients, isolated medial compartment OA. I think it's a better outcome, better operation, and they accept that they may have to have a procedure some way down the line.
Okay, but let's say when it does come to the need for a total knee replacement, what's your, in terms of trying to aim for that goal of making the knee feel as normal as it can be? You touched on there before about preserving the ligaments, the cruciate ligaments. Is it possible to do that with a total knee, or?
To be fair, total knee replacements are generally considered, what we call PCL, sparing or PCL sacrificing. Okay. Generally, by and large, all total knee replacements sacrifice the ACL. There are 1 or 2 knee replacements on the market now that don't sacrifice the ACL.
Okay. So just
the issue is,
what I mean by that. So inside the knee, there's two ligaments called the cruciate ligaments, which sort of wrap around each other. There's the anterior and there's the posterior. And what Joyti is saying there is that most knee replacements, you would have to remove the anterior cruciate ligament, but the aim is to keep the posterior cruciate. But now he's saying there are ones on the market where we can potentially keep both of those cruciate ligaments.
Both of them, yeah. It's technically a more challenging knee replacement. So you're effectively preserving that bone block in the middle of the knee. Yeah. The issue is that, look, again, we very simplistically say arthritis, disease of the bone. Actually, it affects, we know the capsule, it affects the ligaments. and therefore, if the ligaments aren't actually normal, you could be doing the patient an injustice by preserving ligaments which aren't functioning like they should do, or you have incompetent ligaments. You will see where MRI scans show an ACL is intact, but actually clinically that patient's unstable, because possibly other things are going on as well. But anyway, I mean, I think for me, the decision really comes down to, by and large, the sort of top orthopedic companies have got good data, on most, most of the, current modern knee replacements. And I think it's a little bit down to, training, it's down to what you feel. Personally, for me, it's, I try and preserve the PCL as long as the knee hasn't got too much fixed flexion. The ACL is generally sacrificed in a total knee replacement. And I prefer, a knee replacement, which, for me, by and large, you have a number of sizes available. And therefore you're cutting and shaping the bone to fit the prosthesis. Now, again, we have very good prostheses where they have, a myriad of sizes, even down to sort of millimeters in terms of how they increment. And for the vast majority of patients, that will be, good enough. Where patients are particularly, high demand, where it's, really crucial to restore anatomy, or there may be some sort of abnormal anatomy, which you see in different, different morphologies of patients, then actually that's where custom replacements can be, even more beneficial, because you're effectively building the prosthesis to the size of the knee as opposed to shaping the knee to fit the prosthesis.
So what you mentioned just there, the custom prosthesis, is that would that include things like conformists, which people may have heard of?
Yeah, the two that we use are conformists, which were probably the original ones come out, and then more recently Symbios. I do a lot of the Symbios custom hip replacements. They've come up with their own custom knee, and both have potential advantages, disadvantages. I think but the key factor is that they're the prosthesis, you do CT or 3D planning effectively, and the prosthesis is built for that patient.
So I was going to ask you about CT planning and maybe robotics. Now I think there's a lot of info out there about whether the patient should try and aim for, the surgeon should try and aim for robotic augmented knee surgery, which basically means you're using, am I right in saying you're using essentially scans and the robot to show you where to make the cuts and where to make the incisions, rather than using the human eye, so that you get a better fit. Is that how it works?
Yeah, I mean, this is again a very common misnomer that people think, oh, robotic surgery, it's got to be better, it's got to be more accurate. Robots can do things better, and you can argue, yes, certainly in terms of accuracy of cuts, that may well be the case. I think the fundamental principle is that actually is, what are you trying to achieve in this patient in terms of the prosthesis, the alignment, preoperative and postoperative. A lot of knee replacements are designed, we all know in normal anatomical knees, the medial side of the knee, the medial femur is the driver, it's the sort of the round, the lateral condyle is smaller, and actually the knee doesn't sit sort of perpendicular to the floor, it sits at a slight axis, and the tibia is shaped like that. You have a domed lateral tibia and a convex medial tibia, and that's how the knee articulates. Typically when we replace knees, we're actually going for perpendicular, and so in fact we're looking at something called mechanical alignment, and that may be right for that certain prosthesis, whereas another prosthesis manufacturer, they're looking different. So for example, when I do the Symbios custom knee replacement, we're actually not going for mechanical alignment, we're going for what we call anatomical alignment, or actually it's been even kind of more superseded than that, something called natural alignment, which sits somewhere between mechanical and anatomical. So it's the difference from a hip replacement is that, look, are you trying to create the patient's own anatomy? If they're naturally invarus, do you put them back invarus? Are you trying to correct them? If they're invarus, you're putting them to neutral. And this is where, mechanical alignment may have its drawbacks on that respect, because, if a patient's naturally bowed and you're putting them back into, straight leg, it looks good and the x-rays look great, but actually that may not be that good for the patient. And again, that 20% dissatisfaction that I mentioned before, that may be one of the key factors.
Is there a danger though, almost the counter argument to that? I'm just wondering, would it be a case of if let's say the patient, like you say, has got quite bow legs or whatever it would be, and that you argue that their biomechanics in the first place was somewhat faulty, if you replicate that, you replicate a more normal feeling knee, but do you then run the risk of meaning that prosthesis wears out quicker because you're then just replicating their faulty biomechanics? Is that ever an issue?
I think it's definitely something to think about, and again, one can definitely overthink this, and this is the problem. You sit in orthopedic circles, and you can go around, and that's where the thing is that it's actually not so much, one is necessarily better than the other. I think you've got to look at patients. I think where patients are very very bowed or very valgus, where we see in sort of certain rheumatoid patients or kind of Afro-Caribbean populations, that sort of thing. You need to be looking at, you need to ask yourself the question as, what am I trying to recreate here? Because, you can get it wrong. You can get it wrong by putting it where they should be, or get it wrong by correcting it to neutral. But the question is, you need to understand, what are you trying to achieve? It's not just you go in, I had a consultant colleague, just for anecdotally, he said, I can teach anyone how to do a knee replacement. It's that easy,
Yeah.
And the argument is you can, it's just, it's a question, making cuts, but actually it's thinking about the actual patient and the biomechanics and what you're trying to achieve is.
And what that patient is, what their aspirations is, and what you might do for somebody perhaps who's got, severe problems in their 40s and 50s may be different to what you might do in their 70s, because they may want to be, the younger one may want to be more active. I think make a true decision.
Absolutely. I think there's definitely been a vogue from going from more mechanical to kinematic, which is this natural kind of 3 degrees of errors. And, as I say, something, new companies come in and they're promoting different things. I say natural alignment is the next thing that sort of, come along. I think it's just, you've got to understand all the nuances of these and decide on what you're trying to achieve for that patient.
Perfect. So one other little question that sometimes people will see out there in terms of cemented versus uncemented, is that do you have any preferences for that, thoughts for that? What's the
Yeah, it's a good, there's lots of, debates in knees, like you mentioned before, to replace a patella or not, to sacrifice the PCL or not. And uncemented, cemented is another sort of debate on the horizon. I think there's, quite good evidence from the Australian registry. They're big fans of uncemented knee replacements. I think in this country, personally, I cement all my knees. And that's more from training and the prosthesis I use. That's how it's designed. And I think I'd probably say, 95, 98, 99% of surgeons in this country would do the same. There are arguments for uncemented knee replacements if you've got good bone stock. Certainly the Oxford partial replacement, there's an uncemented version of that, which is showing, good data. I think it's not so much, it boils down to personal preference at the end of the day, what you're trained and what you're happy doing. Yeah. And I think there probably isn't as much data on uncemented knees, certainly in this country, to compare. But certainly some of the evidence from Australia is looking good, is tracking good.
And when it comes to knee joints or total knees wearing out, let's say, and you mentioned before the lifespan of the average knee, 90% for 10 years plus, 9% for 10 years plus. But when they do wear out, what's the reasons why they wear out? From what I've understood, it's often what we call aseptic loosening, which for those who don't understand what that means, it's to do with essentially you're putting the replacement into bone, and then over time that bone naturally degrades a little bit, becomes a bit osteoporotic, perhaps gets a bit weakened, and then the thing starts to become a little bit loose. Is that am I correct in that assertion?
Yeah, I mean, I think when it comes to knee revision surgery, the key factor which you made is understanding why it fails. And you're absolutely right. Aseptic loosening is probably the commonest cause of knee revision surgery, but it's not the only cause, and it's by no means isolated. It could be aseptic loosening, but actually there could be other issues.
Yeah.
So understanding, why the knee has failed, even if it is, it's reached its lifespan of, let's say 15 years, in fact, this day and age, we would quote predominantly, knees lasting more than 15 years by an average, certainly a 1% reduction in longevity after 10 years. In terms of, the key factors is actually component positioning, which is really important. That's one of the key causes for problems and key causes why things wear out quicker if the components aren't perfectly aligned. And again, that's where
the plastic components wearing out. Is this what you mean?
Well, it's actually so the plastic aseptic loosening, as you can correctly say, is the plastic, effectively wearing out. So just, metal on, hard on soft bearing, metal on plastic, you slowly wears those micro particles, stimulate the local, what we call macrophages, the cells that sit within the synovium. They then release certain chemicals. Those chemicals eat away at the interface between either the prosthesis and the cement, or the cement and the bone, and over time you get micro movements and then effectively aseptic loosening. So that's the underlying thing, but things can predispose to that. So if your components are slightly mal-rotated or malaligned, let's say, or your prosthesis is not quite, if it's you're going for mechanical alignment and the prosthesis is designed for that, but yet it's in varus and you're overloading one side than the other, then you may be speeding up that process. So those are the things that need to be addressed, as well as the obviously, the aseptic loosening. But by and large, aseptic loosening is the commonest cause.
Does a cemented knee, I think you sort of touched it, does an uncemented knee rather, does that reduce the chance of aseptic loosening, or is there no difference?
Not necessarily. I mean, I think, in the hips, it's very well established where, again, when you're putting cement, people see it as, well, actually, there's another interface there. As you say, you've got the prosthesis cement interface and then the cement bone interface. So effectively, you've got two interfaces to fail. With uncemented, you don't have that option. But uncemented can fail for other reasons, in terms of you're looking at the coating of the prosthesis that then has to, bond to the bone. But effectively that can fail for, from various shear factors and that sort of thing. So that's where it comes down to, the actual, good surgery alignment positioning is so important as well. And
the quality of the bone to begin with, you would say.
Yeah, that's correct. All the time, those patients are getting older. Osteoporosis, has a factor, and then there's other factors. We talk, by sheer definition of aseptic, you can get septic loosening, so a bloodborne infection or a local infection to the knee that can cause early loosening. Component malposition, sometimes bearings can dislocate more commonly on the hip than the knee, but it does happen in the knee. It used to be quite common to have a rotating bearing in the knee, or mobile bearing they used to call it, and sometimes they would spin out and cause issues and that sort of thing. There is, I think the thing, it's generally, there's not necessarily a right or wrong with all of these, technologies and things like that. It's understanding the limitations and, going through patients, what you're gaining on something, you may lose on something else.
Fitting it to that patient. How big a factor is the actual, polyethylene wearing out? So doing just to sort of recap for people that don't really know. So you have the metal prosthesis, if you like, but you don't then have metal on metal. You have sort of plastic components between those, metal, which take the sort of the weight bearing, if you like, which replicate the meniscus and the cartilage in effect. How big a factor are those components wearing out in terms of longevity of these knee replacements?
Yeah, it's a good question. And so, traditionally polyethylene was, generally not well manufactured, quite poor quality, and that was the kind of the spanner in the works. That was the rate limiting step, the poly always wearing out. Nowadays manufacturing is so much better. Oxidation of components causes deterioration, so components come in vacuum packing. Oxidization can also happen from what we call free radicals. These are effectively hydrogen ions causing damage to polyethylene. So for example, cross-linking of polyethylene is, been happening over the last, 8-10 years, where the polyethylene is just made stronger. That causes other problems. You make it stronger, it can be more brittle, prone to fracturing. So again, it's less tolerant, and therefore, again, positioning is important. And then something more recently is coming which is vitamin E infused polyethylene. So those free radicals, those sort of free hydrogen ions, which are causing oxidation, causing that poly to degrade, you now infuse it with the vitamin E. Vitamin E then sort of sticks to those hydrocarbon chains and prevents that oxidization. And you often see it, it's a kind of a polyethylene looks sort of slightly yellow. Initially when you look at it, you think, oh, that looks a bit like an old polyethylene, but it's actually the vitamin E infused type polyethylene.
Oh, all right. And what about the actual bearing surface itself? So again, correct me if I'm wrong here, the traditional kind of knee replacements are cobalt titanium, is that right? In terms of the metal that we're using?
Yeah, that's correct.
And do you see the future going down any other routes in terms of the bearing surface, in terms of getting into things like pyrocarbons and the ceramics, and like they've done on other joints and shoulders and hips, for example?
Yeah, so I think, certainly in hip replacements, it's very accepted that, again, there's a trade-off with all bearings. But ceramic generally for younger patients, ceramic, hard and soft ceramic on poly is probably considered one of the key bearings. Some people would do ceramic on ceramic, and ceramic has come around because it's a harder wearing, much smoother, much shinier, more wear resistant effectively. Yeah. I think in knee replacements they do have ceramic knees. Ceramtech, make it a ceramic knee. I don't. There's no real data to show it has any significant advantage. And, traditionally we use a cobalt chrome knee, which is ultra shiny, ultra smooth on the femoral side, a cross-linked, high molecular weight polyethylene, sometimes vitamin E infused, and then a titanium base plate. The tibial tray is generally, considered titanium. And all these things have, again, a trade-off. Titanium has the closest modulus of elasticity to the bone, and what that really means is that it can sort of, we all know bone undergoes, creep, and there's micro movements. It's a living structure, whereas harder metal, steel, titanium, they don't move as much, whereas titanium has a modulus elasticity which is closer to bone than some of the harder metals, and that has a benefit. But then it can have a trade-off as well if you're using it for example, trauma and plate fixations. Then sometimes it can be useful. You want a little bit of micro movement. Sometimes you need absolute stability, and you want a stainless steel type plate. So there's trade-off with all these things.
Yeah, so it's a complex issue. Kind of penultimate question now. So in terms of the kneecap itself, so what we call patellofemoral disease in the trade. Now, again, you touched on it at the beginning. So sometimes those kneecaps will be replaced, sometimes they won't. I guess that comes down to whether there's actually actual wear and tear in the kneecap, and presumably if there isn't any wear, you don't replace it. But are the outcomes and the approaches, is this like a completely different area in terms of do the kneecaps wear out quicker than the?
Yeah, I think the patellofemoral joint is one of my real areas of interest, and I think even before surgery, it's one of those joints which is not always given that sort of due regard. And in terms of why the kneecaps wear out early in some people and why they don't, it's all due to their biomechanics, and essentially it stems really from the hips, and to do with the version of the hips. Typically in utero the hips are flat, and the femurs develop anteversion. The distal femur then internally rotates, the tibia externally rotates, and that's the normal rotation. So people walk straight, but they've got this rotational effectively that the femurs and tibias are all rotated, and the kneecap will sit. The kneecap, as we know, is a floating bone. So if your femur or tibia are in the wrong position, your kneecap is then going to be rubbing against the wrong surface. So again, we typically see the kneecap as a kind of triangle sitting in a groove, and as long as it does that, it will wear relatively equally. Where that kneecap is flattened, or the whole patellus tilted, you'll get early wear. Where the femur is rotated, that will cause problems with the kneecap sort of sitting on the edge. So all of those things have to be taken into account. In terms of when you come to replacement, how's the decision-making process? I mean, the key, first of all, is obviously data, but also the manufacturer. Certain prostheses, certain companies are what we call patella friendly. They have a very deepened patella groove, and as long as the patient's own patella is good quality, you would try and preserve that. The kneecap is the thing which often is the first thing that fails. That interface between the patella button, let's say, if you're replacing, and the bone is a very sort of generally tenuous fixation. Certain prostheses, certain companies are not so patella friendly. They have a very shallow patella, and therefore you would typically replace the patella in that manufacturer's guidelines, although it's still very much individual. So certainly the company that we use is very is a deepened patella groove, very patella friendly. I try not to replace the patella. If the patella is maltracking clinically, and you can't adjust that on your knee replacement, there's a little bit of movement, a little bit of rotation you can build into it, then you may have to replace the patella if it's very worn, very striated. Sometimes it's so worn, it's so thin, well, actually you're going to cause more problems by replacing it, and even then you would then preserve it. So very, very much individual, but by and large it's not that I have a rule of thumb, always replace, don't replace. It's by and large I wouldn't replace unless I feel it's necessary to the patient's mechanics and tracking.
Right. So just so if I understand that correctly, so the default thing would be, are you saying then the prostheses that you tend to use in terms of the trochlear side, you have a is it a cobalt chromium sort of base to it?
Cobalt chrome, nice and deep.
You have the native patella articulating with that cobalt chrome base. Yeah, is that right? But
That's
then,
correct.
if then the underside of that patella is quite severely worn, then you put a polyethylene button underneath. Is that right? Underneath that patella.
That's correct. Yeah, and you have the ability to offset it, to obviously bring it up and down. So if someone's got, for example, a patella alta, you can actually then bring that patella down a little bit. You can move it a little bit just to sit better in the
population and kind of the orientation, as you say.
And we're trialing these components. Once you've done all your cuts, you're putting trial components, you're seeing how it looks, and then you can still adjust it after that.
And coming back to one of the questions we asked about the tibial femoral joint, I mean, in terms of lifespan of a patellofemoral replacement, if you did have to go down the route of having that polyethylene button on the underside, is there a kind of rough rule of thumb as to how long they last?
So again, I'm a big fan of patellofemoral replacement for the simple reason, generally it's a very specific group of patients who have that patellofemoral arthritis, and their tibiofemoral joint is relatively well preserved. So it's almost overkill putting a full knee replacement in these patients. These patients often have quite significant biomechanical issues, which is why the patellofemoral joint is worn in the first place as an isolated thing, as opposed to the whole knee wearing out. And so the alignment and those sort of things is really important. But I think I would still be doing probably less than 1 in 30 replacements would be a patellofemoral replacement. It's still an uncommon replacement, generally speaking. Or that patellofemoral osteoarthritis on its own is less common.
Yeah. And then how long would they last, would you say?
I mean, again, the data is slightly less than unicompartmental knees. When we talk about unicompartmental knees, even though it's just one compartment, we're predominantly referring to the medial compartment, because obviously you can get a lateral uni as well.
Yeah.
But patellofemorals will be less than that, probably 6 or 7 years, is what the NJR states. But again, the issues with both unis and patellofemorals is one of those things where the data is unfortunately skewed, because if you've got these joints in and perhaps patients then come back to maybe another surgeon, and there's let's say they're coming back usually because of pain, then it's so easy for that surgeon to say, well, look, let's just take it out and actually put a full knee replacement. So they get, the threshold to revise them is much lower, which is why the data is a little bit skewed. Right. Whereas if someone comes back with a painful knee replacement, total knee replacement, most surgeons are going to say to that patient, well, look, it's not that bad. It's not failing dramatically. Let's try and persevere with this. So that's where, just looking at National Joint Registry data doesn't always, help us, it guides us, but doesn't always gives you the answer.
Okay, fascinating. In the cases though, let's say where, I don't know, let's say, for example, it's a hypothetical scenario of a patient who's got, patellofemoral disease, it's been replaced, 6 years down the line, it wears out, the medial and lateral compartments are still okay. How easy and how effective is it then just to do a second patellofemoral replacement? Does that ever happen? Or could it happen? Yeah.
I don't think I've been in that scenario. I mean, it's more one of those what do you call it? Sort of a on paper type scenario. I mean, it generally doesn't happen. I think by the time, it's usually, when the patellofemoral replacement, I mean, obviously it depends on how it's put in and the reasons and all that sort of thing. But by and large, it's progressive wear in other compartments. So you would generally revise, to a total knee. There was a prosthesis out.
Yeah. So you've gone from a patellofemoral and then, like you say, there's other, where the disease has progressed and made it the inside and the outside. You've then gone to a total knee. And as part of that total knee, you're then revising the patellofemoral articulation as well as part of that total knee.
That's correct. Although you wouldn't necessarily, if the patella button, because generally in a patellofemoral replacement, you are actually replacing the patella, as the name suggests. Whereas, again, it depends which, if the patellofemoral was actually okay, and it's more that the tibiofemoral joint is worn out, you can actually preserve that patella button. You just revise the trochlear. And it's a very, it's pretty simple, revising both, certainly the unis and patellofemoral components that we use, the company that we use, it's actually, very minimal bone that's being lost. If you look at the conformis partial, unicompartmental knee replacement, it's almost considered like a resurfacing. You're literally replacing the cartilage as opposed to even taking bone. You're literally, you're just down to the subchondral layer of bone, whereas most patellofemoral will cut a little bit of, cancellous bone. Oxford knee replacement, for example, mills quite a lot. So there's pluses and minuses with all these things, as I've always said. But for me, you either patellofemoral or unicompartment. If you're going to revise, you'd probably just go to a total knee replacement.
Okay. So what you just said there, and about the conformis only literally taken off the subchondral cartilage. Are you talking about on the trochlear side or the?
No. I'm talking. So unicompartmental knee.
Yeah.
So partial, medial compartment knee replacement, and literally you're just, you're shaving back down to the subchondral bone. You're then drilling that bone effectively to create the, that sort of bleeding, and then the conformis. So it's very much a curved prosthesis. It's just literally recapping it, as opposed to other partial knee replacements.
But for the patellofemoral specifically, though, you do conformis then do a patellofemoral as well? Is that
no, they don't. Okay. They do a patellofemoral and a medial sort of knee replacement. Can't remember the name of it, but again, it's a sort of, I guess I think a company called Smith and Nephew used to do one called the Duo. It's a very you're getting into a difficult area because you're trying to treat, use one prosthesis to treat two things.
Yeah. And
sometimes the anatomy doesn't allow you to do that. Sometimes it does, sometimes it doesn't. Right. So actually what people have done is what they call the boutique knee, which is, you do a patellofemoral, a separate uni, and then if it need be a separate lateral uni.
Right.
And thereby you've preserved all your ligaments. But actually in practice, it's technically very challenging, and you've got more, in my sort of eyes, more to go wrong. Yeah. Although people have done that,
Sure. And just kind of last question really for me, in terms of, again, just homing into those like the patellofemoral buttons that you mentioned, if they do need to be replaced, is that an easy job, or does that have complications in terms of having to then?
It's an easy job to replace. I mean, that's the thing. It's just, it's a small area. It's a small, they're generally cemented in. Although you do get trabecular metal. Trabecular metal is a kind of a mesh metal where, for an uncemented button or an uncemented prosthesis, it allows bone to grow into this mesh. But generally, most patella buttons in this country are cemented in, so it's relatively easy to take off. The issue becomes, once you take all the cement off, how much bone is left. And sometimes, you may need to consider, bone grafting that area or building it up to get the right sort of patella height. Right. Obviously, there are revision patella buttons designed to, to compensate for height. Offset buttons and things like that. So
yeah, sure. So it's like you say, it's quite.
But it's generally considered the weak link in most, knee replacements, which is why, I try to, not try, but it's by and large, patients have got a good patella, then you would try and preserve their natural, patella.
Yeah. Okay, fantastic. I mean, that's really, really fascinating and informative. So, yeah, thank you.
Yeah, I mean, if nothing else, it shows you that it's, it's, one thing to say, oh, let's bang in a knee replacement, that's what we typically hear. But actually, if you, dissect it down, it's more complicated in
Yeah,
terms of, how you approach that individual patient. And I think going back to the basics, history examination and good planning
coming
is the
down
key.
to coming down to the right decision for that patient. I mean, is there in terms of patients who are, you know, towards the sort of the younger side, you say, of knee replacement, so 40s, 50s, maybe even early 60s, is there going to say who are, who are quite active, is there a rough rule of thumb in terms of, trying to fall down on some of these issues we touched on, in terms of, would you try to go more for cemented versus uncemented? Would you try and go for, well, you mentioned try and go for unicompartmental?
Yeah. I think for me, the key decision making is look, one is always looking for options to try and avoid replacement in the first instance, and therefore going down the route of biologic therapy, and we haven't sort of touched on things like subchondroplasty or scaffolds and things like that. When it becomes a bit more advanced, those things are for me, you've got, you're not burning any bridges as soon as you replace, because we do sometimes bespoke replacements where you effectively got an area of cartilage loss, and you'd actually put in, traditionally people used to put metal, these kind of very small, company called EpiSurf, where you put a very small sort of metal button into that sort of defect. Nowadays you can do it with high molecular weight polyethylene, and that can be a good option when there's sort of a larger defect, but still not so bad that they need a partial replacement. So you still have the option. Well, look, if it doesn't work, or you give you 5, 6, 7 years of use, and they've been very active, energetic, then you can still revise that to a partial replacement. If you go to a partial replacement, 5 years earlier, then you can then run into trouble where 5 years later you end up having to do a full knee replacement. So kind of things give you more bites of the cherry, as it were. That's how.
What's the name of that? What's the name of that procedure you just mentioned there with the?
It's called an EpiSurf, which is the custom replacement. So what happens is that you see an area of defect. It's a bit bigger than what you could microfracture, or you can use a scaffold, or the patient's a bit older, where that, well, look, scaffolds may not work. I mean, the issue with scaffolds is that they're all good in terms of biology, but actually you've got to then that patient's going to have to be non-weight bearing for a long period of time. It's going to take several months before it actually fills in and heals, if it before it's a success. Whereas if that patient can't afford that sort of time off, then actually you could put a custom button into these areas to fill that defect. The other thing we do for, again, younger patients is what we call an Oates procedure, where you're taking cartilage with bone from a non sort of weight bearing part of the knee, another part of the knee, usually the lateral sort of edge of the knee, and you take a core of bone and you fill that into that defect. And again, that works for defects 5, 6, 7, even up to 10 millimeters. But if you get beyond that sort of 15, 20, you either then have to do several of these plugs. That's called a mosaicplasty. And again, there's issues with that. Or you can do one of these kind of custom buttons, or even off the shelf buttons. They have that sort of the oval shape that you put into that area. But I think it's just you've got to have options. You've got to know what's right, and at the end of the day, it's that conversation with patients. What are they trying to achieve? How quickly they want to rehab? Are they happy to take something that's a slower, prolonged thing on the basis that they're preserving their natural knee, or is it that their job or their work or their sports doesn't allow it? They need something which they can rehab a lot quicker on, and so you've got to have those decisions.
And you mentioned the scaffolds and that sort of thing. So this is people might know this in terms of terms like microfracture or autochondrocyte replacement, or Macy's technique, which is a membrane autochondrocyte implantation. Generally speaking, am I right again? And they're more suited towards isolated, cartilage lesions where there's just one little osteochondral defect as opposed to the whole knees being diseased, or there's multiple sites where this
yeah. I mean, the best analogy I can use is that if you think about the knee surface as akin to a road. So if that road is, you've got freshly tarmac road and there's one pothole, we see it in the snow and ice and that sort of thing, and there's one sort of pothole, those are the ones that respond well to some kind of either drilling that area or putting some kind of scaffold, some kind of filler into that zone, because you've got an edge to it that will allow it to stay in, Where your road is more sort of crater shape, more kind of gravel, there's no one area that you can sort of, you can try and patch up one area, but the other area is just as bad. So you then, in those sort of situations, just going down the biologic route or the replacement route, depending on how, severe the symptoms are, would be the better option. So the scaffolds, sorry, go on.
Yeah, so the other thing that people might sometimes have, they might experience, is they might have, because a knee is a bit like, you say, like a road. It's actually like a road on a road, isn't it? So you might have a pothole on this side, but then a matching pothole on the other side. That's what we call a kissing lesion. And again, that's not an ideal combination if they've got that, because I think, is that right in saying? Because again, it's going to be harder then to stimulate and flatten off those two.
Yeah, if you scaffold both sides, then it's probably going to fail. So I think when you've got those kissing lesions, then you've got to look at different options. But we try and do. I guess our philosophy is always trying to do the least possible in terms of least possible to get the best results. To try to enhance the patient's own bone, whether it's stimulating that with what we call a subchondroplasty, where you put calcium phosphate into that sort of stressed area of bone, and then doing some kind of cartilage work, as opposed to just jumping in to replace. But again, it depends on that patient.
An end game point, really, isn't it? So. Yeah, fantastic. Okay, well, we'll wrap it up there. That's really, really fascinating. Thank you so much again.
No problem, pleasure.
Watching these videos, found it really useful, and it just gives a bit of an insight into the complexities of knees, and particularly cartilage issues, and the different decision-making processes and options that are out there. So, Joyti, thank you very much.
Thank you. All the best, Rob. Cheers.